So people, today we're talking to Nasha Winters, and I think you know all about her. If you don't know, you'll get to know her better today. So it says in Portuguese and in English, so it will be in Brazil. You'll have like Portuguese subtitles, and in English, of course, not. And it will be posted in my English YouTube. And Nasha will have the video for her, so she can post it as well if she likes. Então, pessoal, esse vídeo vai ser traduzido, vai ter legendas em português, só que não é agora simultaneamente. Então, amanhã a gente vai colocar, teoricamente, vai funcionar a partir da meia-noite. Quem quiser, depois quem não fala inglês muito bem, vai poder assistir isso depois, tá? Com as legendas em português, ok? So, let me open it here. Não estou conseguindo abrir ainda. O meu ao vivo. Ok. So, welcome, Nasha, to Metabolic Podcast.
So good.
I'm Janaina Koenen.
So good.
I'm an endocrinologist, a medical doctor endocrinologist, and I love studying about metabolism and everything regarding mitochondria. Strikes me, and about cancer, Alzheimer's, endometriosis, and nowadays I work with aging as well. I love studying about aging. But this lady here changed my life because I met her at a Metabolic Health Summit a couple of years ago. And I was lost because I was studying on my own. I didn't know anyone. And after my father died of cancer, of lung cancer, in 2017, it's like some minutes ago, I began studying about metabolism in cancer. And I met her. And she was so open. Oh, my God. You were so open. Oh, I get emotional because you really opened the door for me. And then she said, have you read Jane's book? Have you read my book? And I said, no. So you have to read these books. She said, okay, I will. And then I bought immediately books. Immediately I bought them and I read them. And Nasha's book is here. We'll talk about it in a while. And okay, so after I met this woman here and after I started reading all the books, I was reading papers like alone. Everything made a connection. And now I'm here. And I'm very, very happy to have you on my podcast. I can't say how glad I am. Thank you so much. I know you're very busy. So I'd like you to introduce yourself to my followers and tell them all about you. And then we'll talk about your story, which is very, very strong. Okay, so come on, talk.
Okay. Well, first of all, I think that you make me emotional because you are a force to be reckoned with. Myself and my entire team that I was at the conference with at the Metabolic Health Symposium when we met you, we took to you like a fish in water. You are just a beautiful, beautiful thing and exude such vibrancy, which is very magnetizing. So I just want to feedback that to you. And I feel like there is so much work that we get to do together on this planet. And I'm so very saddened that you had to be exposed to this metabolic approach to cancer because it touched you very near and dear to your heart and soul, which is how I ended up having this conversation. I think that anybody who decides to work in the field of cancer, it's because we've been touched by it, either personally or with somebody very, very near and dear to us. So my name is Nasha Winters. I'm a naturopathic oncologist. I also have a doctorate in Oriental medicine. I also studied Ayurveda for 13 years. I love all things integrative medicine, but I also very much love the sciences. I love epigenetics. I love polyomics. I love the off-label drugs and the utility of the metabolic pathways those can impact when in the right place. So I kind of bring the best of both worlds, the best of kind of a re-envisioned standard of care with also a well-vetted, evidence-informed alternative or integrative approach, and have brought those together and wove those together over the last 3 decades. So that's what I do for a living. I'm now the executive director of a nonprofit hospital, currently virtual, and research institute. I have the pleasure of training physicians from all over the world, including you hopefully joining our team here in the fall. We have 160 physicians from 16 countries that have been trained in the metabolic approach to cancer. We have 300 patient advocates from 16 countries trained in how to be the bridge between the patient and the physician. We are building a data platform. We are building a metabolic lab, and we are building a beautiful campus where people can come and learn how to live healthy on this unhealthy planet. And then hopefully that will be the starting point of many campuses spread across the planet. So that is what I've got going on after 30 years of my own cancer journey that's brought us here together today.
So, and I learned you're building a big place there. It's in Arizona, right?
Correct.
I'm in line already to the fellowship there. So
Yay!
I might as well
She'll be pushing her way.
Yeah, I might as well revalidate my diploma just to do that, But,
yes.
And yes, as I said, I've been studying on my own for a while, and I have lots of mentors. But of course, I will join your team in the fall. Hopefully. I think the more we share, the more we talk to each other. Every time I sit with you, like for 5 minutes, things come out. It's like Ahmed. And I know Ahmed is coming as well with you. I'm so glad because he's worth it. He needs it. And I think he will make a big difference as well. So everyone, when we sit and talk for 5 minutes, something goes on, something happens, and we have these insights and these ideas. And I think the more we get together, the more we can help more people. Especially when you have this whole idea of the oncology field, like, but this is not backed up by all the guidelines. I had this message last week. Oh, but this is not in the guideline. I said, okay, but usually most of the guidelines are not grade A evidence. They're like C or D. 80% of American Heart guidelines are C evidence, which is not much, is it?
Yeah.
And yet, if it's not in the guideline, it doesn't work. So I said, okay, so maybe we have to have a second look on literature, on scientific literature, and see we have randomized clinical trials and some stuff which might as well be read, right? And when you say you have this Oriental background and also the scientific background, I must say I have a lot of respect in Chinese medicine and also Ayurveda. And the more I read about supplements like Danshin, for example, and like ashwagandha, or even curcumin is like from Ayurveda, right? There are supplements that are used for 1,000 years. They're safe, and of course not in every chemotherapeutic regimen. Some things we have to adapt, of course, but we learned a lot from them. And sometimes things don't have lots of evidence, like strong evidence, grade A evidence, because they're cheap. Too cheap for people to study them, right? If they don't have profit out of it, So I have lots of respect from this part of your background, and also the emotional part of it, the stuff of the mind, the work in your mind, the mindfulness, and the positive thinking, and how this impacts. We have strong evidence about it already in immunity and in cancer as well, and even in survival rates in cancer patients. So I think when people see, okay, if we tell you do positive thinking, you say, oh, that's whatever, you're wrong, man. You should study more. You should read the evidence. There is evidence. So now, thanks God, people are starting to look at it and see that stress is killing us, right?
Yes.
So, but I really like people to know about your journey, because you're a survivor. Like, you survived the doctors, the disease, the doctors. Right? And the unbelievers, the non-believers, the non-supporters, you survived them all. Like, how could you do that? Because you had a mission, and now I know. I think now you know too. But you didn't know back then, did you? How was it?
No. Well, it's interesting. Honestly, I tell people this is kind of the hardest part of the story, is that there was a time in my life before my cancer diagnosis that I just did not want to be here. It was a difficult upbringing. It was a difficult, challenging environment to come from, and very kind of hidden. I did a very good job wearing my masks to overcompensate out in the real world, but behind closed doors, it was pretty dark. And so for me, when I'd had a lot of health issues, even from being a little girl, so my symptoms just looked like an evolution of symptoms I've had since my entire life at that time. So I had a lot of digestive issues. By the time I was 9, I started my period. By the time I was 11, I was diagnosed with endometriosis. By the time I was 14, I was diagnosed with polycystic ovarian syndrome, endometriosis. I'd been on birth control pills for many years to help deal with those those symptoms. I had worsening of my IBS. I had early onset rheumatoid arthritis patterns. I had cystic acne. I mean, I was just a hot mess, but I didn't know that because it was normalized. It was like, oh, take a pill for that, take a pill for this, just do this, just do this. So by the time I got really sick in my sophomore year of college, the summer before my sophomore year of college, I was landing in and out of the ER every month with excruciating pain. And they'd load me up with narcotics, and then they'd load me up with anxiolytics because they thought I was just being anxious. Then they'd load me up with antibiotics because I kept getting UTIs. And then they'd load me up with antifungals because I get yeast infections. And you can see the crazy cycle, right? So 19 years old, I had a whole collection of pharmaceuticals on board, a whole collection of diagnoses on board, a lot, as you alluded to, stress and emotional and trauma and abuse history on board. And for me, the way I compensated for that was to do more. So to be an athlete, be in politics, be in sports, be in all the different things that kept me busy and distracted me from dealing with my day-to-day life. And that caught up to me at the time. So by the time I was just shy of my 20th birthday, my roommate drove me to the ER because I couldn't breathe, because I was so weak, because I was in so much pain. And at that time, they realized I had a belly full of fluid. I had fluid around my heart. My organs were in end-stage failure. I was severely malnourished, and I had a bowel blockage. And that was what was causing me to vomit and have excruciating pain. And so that's when they finally looked a little bit deeper than just writing another script and realized that I was in stage 4 ovarian cancer that had metastasized to all over my abdomen, all over my liver, and my organs had decided to give out as well. So it was a crazy time, as you could imagine. It was a shock for everybody. Even though I knew I was really sick, I didn't quite expect it to be that sick. So that's what landed me in front of you today is, why would a 19-year-old be dealing with these issues? And I want to point out to you and your listeners, I had no expectation and no intention of surviving this, especially back in 1991. So we're coming on 32 years of this journey in October of 2023. So there wasn't Dr. Google, there was no internet, there was nothing that I could have done my own research on. So this is where I landed, is at my own devices. I had to just kind of figure out how to make myself comfortable the best I could. And because I was so sick, they couldn't offer me any standard of care. It wasn't an option because my organs had already given out. And so because of where I was now in retrospect, I got lucky in that the only thing I could do was fast.
But you were undernourished.
I was severely undernourished.
How much did you weigh at that time?
Well, my weight at that time was 125 pounds, but that seemed heavy for me. But almost all of that weight was ascites, was fluid buildup. So when they started to pull the fluid off, I got down to about 112 pounds. So they pulled 12 pounds of fluid, almost 13 pounds of fluid off, but it filled right back up. So I kept vacillating between, and just so you know, my healthy weight is around 140. I'm a big girl. Like I'm a tall girl. Yeah. And so 140 to 150 is kind of my zone of when I'm in balance. So I was already 25 pounds underweight, but I looked weird because I had this huge big belly, but that was full of water, and my limbs were little stick figures. I mean, I was severely cachectic or sarcopenic, meaning my muscles had broken down, and my body was putting all of its energy just to keep the organs alive. So I was starving to death while feeding myself. Now, because I couldn't eat for a few weeks before I ended up in the ER, I was already fasting accidentally. And then I wasn't able to eat for a few more, almost 2.5 months in total without food. And so that freaks people out when I tell them that story to this day. But my body was utilizing all of its stored materials, and it was utilizing, putting all the energy towards healing my body versus towards digesting my next meal. And because I had a bowel blockage, I couldn't take anything in, and I was too weak for them to do surgery to create a bypass for that. So everyone was expecting me to be dead very quickly, and myself included to some degree. But somehow I think the fasting helped take some of that inflammation away and help my body auto-digest a lot of that fluid and help me buy the time I needed to start to understand what was happening bit by bit by bit, which I'm still learning all these years later, of what makes my body tick. So it was a very odd time, as you can imagine, and nobody knew what to do with me, myself included. And I accidentally stumbled across a book called, oh my gosh, I can't believe I'm just blanking on this right now. Deepak Chopra's Quantum Healing was the book that in 1991, you guys, this guy was relatively unknown. And now he's somebody that everybody seems to know. He's like a household name. But those were the interesting pieces of this journey, is sort of learning things on the fly, learning things as we go. And to your point that you made earlier, there was no data or evidence about anything that I was doing. And it's funny because today, 30 some years later, we have evidence that intermittent fasting can actually be very helpful with disease. And we actually learned from some work done in 1909 by Dr. Moreshi that fasting was actually a really good way to debulk a tumor. But somewhere in about the 1960s, 1970s, physicians got scared of fasting their patients and pushed them away from that, like, oh, how dare we, make them suffer any further. And yet for me, it's probably was one of the first real things that I did that saved my life. And that wasn't by knowing, right? That saved my life big time. Yeah.
And did you get parenteral nutrition or enteral nutrition at that time in these 2 months? Just IV fluids?
I did not, because they sent me. I did some IV fluids and minerals because at that time they even had to be careful with the IV fluids because of the fluid buildup in my abdomen. So they'd pull out a little bit of fluid. They couldn't even take it all at once because it would throw off my electrolytes too much. So I had to come back for several taps over several weeks, but I'd fill up very quickly. But in the interim, they'd give me some fluids because my sodium levels were really, really low. So they'd give me a saline bag, very small amount. But I really had to just go by sips of water, sips of tea. Down the road, I was able to get in sips of broths, mostly because I was vegetarian then, I was vegan then. So I was doing sips of vegetable broths, bouillon broths of that nature. And so that's what kind of nursed me back to health, was taking my attention away from trying to digest and focusing in on my body, trying to just rest and heal, because it was working very, very hard at that time.
Okay, we can discuss fasting then after stuff about fasting afterwards.
Bring it back.
Because I really because I don't want to lose any bit of your story. So did you?
Yeah.
And what about what happened then? Okay, you didn't die, and I mean they couldn't believe it.
Didn't die.
Yeah.
Well, this was September. So I turned 20 September 30th, 1991. I ended up in the hospital 2 weeks before that, so I was still 19. My official diagnosis did not come until October 21st, 1991. That's just the nature of the beast back in 1991 in a small town. We just didn't have access to the types of imaging we had today, the types of labs, the type of pathology. It took time. And at that time, they were telling me I had 3 months to live. So there was really no expectation that I would live much into 1992. So here it was. I didn't expect to see my 20th year on this planet to fruition. They didn't expect me to see even the beginning of the next year into fruition. And so my expectations weren't on healing myself. That was not my expectation or my focus. My focus was to understand why. That's where I put my energy, was into understand why I got cancer. That's what was interesting to me at that time, because I was very at peace with death and dying on one level, right? Because I'd already tried to take my life, and I'd already been around a lot of death and dying. I actually worked in a nursing home and did postmortem care, and I lost one of my best friends when I was in 8th grade. Like, I'd already been around some of these experiences. And so that was not what my concern was, but I didn't want it to be painful. I didn't want it to be, for nothing. And I wanted to understand. And so to your point, where I put my energy outside of fasting, I put my energy towards pain management, which is where I started using acupuncture. There was a local acupuncturist. She was helping me with pain management and with helping with the digestive symptoms that were really terrible at that time. So she was incredibly helpful for my pain. I worked at that time at Planned Parenthood as kind of like a receptionist and did like reproductive counseling and helped women understand their bodies and helped them get their birth control pills, things like that. But that's also where I was able to do my labs and to do my pelvic ultrasounds and follow-up imaging. They were willing to help me. So I was doing my kind of testing in that environment. And so between acupuncture, fasting, testing, what I also then put full focus into was the mental emotional trauma. And at that time, I worked in an addictions unit where we were part of a Native American community, an indigenous community. And I started working with some of the shamanic healers in that area, because they would come and work with the folks in our facility to do work with folks dealing with addictions. And so I thought, well, I'd been on a few of those experiences. Perhaps they could help me with just my own healing. So I started working in that, and I started working with a therapist doing EMDR at my college. There was the first EMDR, which is a rapid eye movement therapy for trauma, and started to really unpack the childhood trauma and abuse that I had endured. And so for me, focusing so deeply in that was very critical, and to the point where I actually changed my degree. I took off a little bit of time from school, but when I returned, I changed from biochemistry and biology to biology and psychology, because to your point, I recognize this is back now into 1992, that a psychoneuroimmunology degree was where my interest lied. Because what I started reading about from the work of Dr. Robert Ader, from the work of Dr. Candace Pert, from the work of Dr. Bruce Lipton, from that book, Quantum Healing from Deepak Chopra, was how much trauma and emotional and mental well-being impacted my immune function, my endocrine function, and my overall ability to stabilize disease and heal myself while understanding where I came from. I had some instinct that my trauma had something to do with my illness, and it would take a few more years before the research was really published to that effect. But we now understand a concept known as adverse childhood events and their impact on future potential for disease, chronic disease, and cancer. And so basically, for every yes you have of this 10-part questionnaire, your potential of having a chronic illness or disease, cancer process goes up exponentially. So basically 10% chance at 1, 20% chance at 2, 30% chance at 3. To give you an example, I was 10 out of 10 on my ACE score. And an ACE score is measuring experiences you had before the age of 18 that included things like poverty, any type of abuse, addictions, incarceration of anybody in your family, those types of things. Those were all part of my experience, my upbringing, and what I experienced. So I was 10 out of 10. So suddenly it was making sense to me. Why? And so part of my healing was I did a family fast as well as a food fast. And so I needed to extricate myself from the environmental soil in which I got sick, which was so much around my family of origin. And so I really pulled away from that part of my life in order to save myself.
So I'm so sorry to hear that.
That's okay. It's what has made me exactly who I am today, and I'm a tough cookie. So
I mean,
resilient.
If you hadn't gone through all of this, you wouldn't be here today. I think this is
100%.
Yeah, I know. I've been some bad stuff too, and I know that I wouldn't be here today if it wasn't because of that. So okay,
exactly.
But
it's the gifts of that, right? It's the gifts that come from that experience.
But I mean, you left the hospital after 2 months and a half.
Well, I didn't stay. They sent me home.
They sent you home to die without medicine, without anything. Okay. And you didn't die, of course.
No. Well, they sent me home with pain meds, but the pain meds made the constipation, made the blockage worse.
Yeah.
Because it just clogged up things. So I couldn't tolerate those.
And that's
so
good.
It was pretty terrible.
That's good because you know that opioids have receptors in cancer cells. That's why we use naltrexone too. So
Exactly.
So they would have killed you faster. So opioids are 100%. The worst meds. I mean, anti-inflammatories, if they didn't have so many side effects, would be okay, right? But opioids are like the worst. Nowadays,
I think, that.
Yeah, I mean, I tell my patients, they're like, "Oh no, I'm on morphine." I said, "Oh, I mean, let's try, cannabis. Let's try CBD, CBG,
Exactly.
stuff like that.
Exactly.
Yeah, acupuncture. So anything. Let's
Exactly.
try something else. If because I'm get desperate when I see them like
Exactly.
overdosing
Right.
opioids because it just accelerates the disease, right?
Exactly.
And doctors don't look
directly.
at it. They don't see it.
No.
They just don't know
No.
it. I think they don't know it.
Yeah.
Okay,
and it's funny when I explain to people about that part, people think I'm crazy. When I in private practice many years later, I started doing pain management for patients who quote unquote failed hospice pain management. So basically when the opioids stopped working, they would bring me in to do acupuncture and homeopathy for the pain management. And suddenly the patients would improve.
This is better.
And everyone would be so confused, right? They're like, I thought it was supposed to be dead by now. And you're like, and sure enough, they would like linger longer or even stabilize to the point where they'd have to come off of hospice over time. But that's where the literature is very, very clear that opiates, like you said, cancer cells really upregulate those opiate receptors, but it also drives cancer proliferation in general. And so we do everything in our power to educate and empower patients to avoid the opiates. And to your point, find all of the other alternatives that can be much more effective.
We could have a podcast.
And you nailed it. Exactly.
Only about pain. Let's do only about pain. Let's do it
because there's so much more.
Okay, yes. Let's do it. Next one. Okay.
Perfect.
Yeah. It's great because people need it. I think they're completely lost. Everyone's lost. It's so bad.
And it's our default. Like write the script. We just want them to be out of pain. And sometimes, remember, pain is a messenger. It's trying to tell us like something's wrong, something's structurally wrong, something's energetically wrong, something's emotionally wrong, something's physiologically wrong. And so when that happens, we try to suppress it with the opiates, which can only hold back the floodgates for so long. And so there's different means like understanding exactly what the pain is about and then directing treatment towards it. Like you noted, anti-inflammatories have much more utility when they're used precisely at the right time and the right dosing, that can be far more effective in managing cancer pain than any of the sort of pressure cooker lid of the opiates we often apply first. So,
Oh, and but then you were home then, and you did this 2.5 months fast, and you started working during this 2.5 months. And did your ascites go away? Were you stable to go out working? How did you feel then? Because you had end-stage cancer. You were not on chemo, only on painkillers. You were on your own, and you went back to work.
Yeah.
That's right.
And school. I was in school as well. And so luckily I had one professor who understood what was going on. So he kind of vouched for me when I had to take breaks from different things. I'm a really fast learner. So I could take a lot of my work and just pretty much go home and study on my own and show up for the tests. So I was able to manage that. I worked grave shifts, which is now I understand that was probably a really bad idea. So I worked detox graveyard shifts. And so there'd be a lot of downtime. That's when I could study and have really quiet time that I didn't have to do a lot except for just checking people in when they came in. And so that gave me space to do things. I had to pull back from working several of my other jobs that required me to be on my feet, like waiting tables. I had to take a little break from things like that. So I was still working pretty much full time and I was still in school pretty much full time, but my schedule allowed me to be pretty flexible with it. And I was able to hide this. The only people who knew was one of my professors, obviously the people I worked with at the Planned Parenthood, because they were doing my testing, and my then boyfriend, who's now my husband.
Oh yeah.
Those were really the only, and one of my girlfriends, those were the only people who knew what was going on with me. I was very, very private about this because you have to also remember first, I came from such trauma. I did not want to deal with that. That was something I was not ready to talk about or deal with. And so there was that piece. So it's like, if I had to face my cancer, I'd also have to face the trauma. I wasn't ready to do that. So there was a therapist also in my college that I worked with. So they knew as well. My acupuncturist, she only knew I had digestive issues. I didn't tell her for a couple of years what was going on because she would have refused to see me.
Yeah, that's
so
true.
I knew that. And so that was pretty tricky. Thank God she was very, when she found out later, she forgave me for it pretty quickly. We became very good friends. It's pretty wild. But with that, I also wanted to be like a normal college kid. Right. I came from such trauma and drama. I wanted to have one place of normalcy for my first and only time. I left home a week after I graduated high school to go to a different state, to go to school. It was my chance to break free. And so to have this come up for me I was angry at God. I was angry at the world, and I just wanted to be normal. So I did my best to try and look the normal part. I also sold everything I owned about 6-7 months into that process and took off backpacking because I thought I'd be dead. So I thought, well, if I'm going to go, I want to go see the world. That was something that I was able to do at a very young age. And then that, I think, was part of my medicine. And so these weird little things that were happening between the counseling, I also changed my diet pretty drastically. I was already a vegetarian. Then I went vegan, and then I went raw food vegan, which back then was probably helpful because I'd eaten so crappy for so long, very fast food, junk food, that it was probably cleaner, but it wasn't nourishing me. So I stayed pretty malnourished for several years in that time. But the fluid finally started to resolve. The pain resolved. My bowels started moving again. And I just started teaching myself. I started learning everything I could and reading everything I could to understand what was happening to me. And that's what got me going into medicine. I was already planning on going into medical school. So I actually hid my diagnosis because I was afraid they wouldn't let me in. I had one professor who was my clinician, and when I started naturopathic school, that knew my whole clinical history. And basically, because it was HIPAA, she kept it very private, the best that she could. So I had to keep living this weird life of hiding what was happening with me so I was perceived as normal, which no one would ever perceive me as normal in any normal day out there. But it was just this weird thing because I was like, I don't want cancer. I don't want anything to do with it. I don't want to associate with it. I don't associate myself as a cancer patient. I just need to get through it. And ironic that when I graduated from school, my first patient, I was never going to work with cancer. That was the plan. My first patient came rolling in a wheelchair, wanting acupuncture for pain management, for end-of-life pain management for his glioblastoma.
Oh my God.
That's what I said. And it was, his imaging showed that his ventricles had already closed. I mean, we're talking days out. He'd been mismanaged by a fake naturopath who said he had a parasite and proceeded to put him on basically a carrot juice fast, which just fed what we now know, fed his cancer so quickly. His parietal lobe was bulging with the pressure of the tumor. He was in a diaper. He lost all of his bodily functions. He couldn't walk. He was moaning and crying in pain on so much morphine it wouldn't touch it. So when he came in, he was also having seizures, like 100 seizures a day.
Oh my God.
So and not being managed by any of the seizure meds. So that's when I said, it's time to apply a ketogenic diet. That's the only thing that I knew. And I didn't think he'd be able to go from carrot juicing to that, but he had 3 little kids and he wanted to spend as much time with them as possible. And he wanted out of pain and he wanted the seizures because that was very traumatizing to the whole family. So between that, acupuncture and homeopathy, we got him completely out of pain. He lived another 18 months. 18 months. Yeah.
Ketogenic diet is
out of the
great.
He must out of the wheelchair.
Yeah. And an IDH mutation, right? Because.
Well, gosh, this is back in 90.
So. Yeah.
Let's see, 99, 2000.
I mean, response.
This is way back when we didn't know any of the things we know today. And so that's when I also started making the connection for myself of how much sugar was driving my process, because I was a very high carb vegetarian, vegan, moved to vegetarian. And so I started making those links for myself early on because I could not get my cancer into a really stable remission or maintenance process. And I started to understand that was probably playing a role. Okay. So even though I did a lot of fasting, that helped, but I still wasn't low carb at that time.
But then, Nasha, at this point, when you saw this first patient, how long had your cancer been already?
I was, by the time, so my diagnosis was in October 1991.
Yeah. And
I started clinical practice in December 2020.
So what?
So,
whoa.
Excuse
9
me,
years.
2020, yeah. So let's see, hold on, I'm getting this through. Sorry. In 2000, December 2000. So 9 years.
So, and
I'd already been dealing with this.
And your cancer disappeared or you still had lesions?
I still have lesions.
You still do. Okay.
Yeah. But nothing moves. Nothing does anything.
Yeah, because there's something I wanted to talk about this a bit. Why? Let me tell you why. Sometimes we start a metabolic treatment with patients. So I have some patients, I tell them, listen, if you have stable disease, that's great, because usually despite chemotherapy, radiotherapy, you get worse. So if you have stable disease, it doesn't mean you have to die from it. But sometimes people give up treating their cancers with a metabolic treatment. And they said, I'm going to stop. It's not working. I said, you don't know. You don't know if it's working or not. And I had 2 patients already that stopped taking the meds and said, it's not working. And by the time they stopped, until they saw the other doctor, the cancer like really grew and they had complications. And I said, you see, it was working. You know, and my father was the same thing, because he was doing pretty well. He had like 35% necrosis of the tumor. He had a huge lung tumor. And because of the necrosis, he had edema and venal cava syndrome. And that's why he went to the hospital. And then, and when he saw the images, he said, my God, this tumor is huge. I said, yeah, that is huge. I'm going to die someday. Yeah, but I'm going to die from it. Who knows? You should be dead already. They said a month. It's like 5. You're here. And then he was, I'm going to die anyway. I want to stop this diet. I'm going to eat anything I want. I said, okay. And then, like some people in the hospital, they said, oh, now he's going to gain weight, right? And then he started eating carbs. In 6 days, he lost 7 kilos and died. And by then, I didn't know anything. I knew exogenous ketones, ketogenic diet, metformin, some supplements like curcumin, nothing much, you know? It was the diet. So some people think if the tumor doesn't disappear, it didn't work. So I'd like you to talk a bit about it.
Sure. You know, and this is the thing is, for your listeners, like, remember, we all have cancer, all of us, all the time. There is no such thing as a cure for cancer, because cancer is part of us. When it gets big and loud and catches your attention, it might need some pushback of some sort. You do not have the ability to make it 100% go away. That's literally not possible. And for you to overtreat it to that point that you alluded to will often push people off the cliff. So how we approach cancer today in standard of care is known as maximum tolerated dose. That means we push as hard as we can with as much oxidative therapies as we can, be it chemo, radiation, targeted therapies, hormone blocking therapies, surgery, even oxygen therapies, high dose IVC, aggressive oxidative natural substance therapies. You can oxidize too much even from the natural side of things. So when patients push too hard in that area, there's like a backlash, right? And that maximum tolerated dose is not effective for the long haul. Some people get lucky and it may seem like it buys them some time. Most people, unfortunately, it can make things worse. It can make things either recur or progress pretty rapidly. So there's this concept known as the adaptive theory of cancer. And this is what I intuitively subscribed to all of those years back, and what I have found to still be kind of the best fit for my practice and my consulting today, which is the idea that obviously if things get really big and loud, you need to push back some. You need to buy some time. You need to create a little bit of moat of safety. You don't want things encroaching on, vasculature or other organs. You don't want blocks. You want to push back a little bit. But people like Dr. Rosenberg, people like Dr. Gatenby's work in the adaptive world, they talk about if you push it back just enough, then the rest of the body has the ability to swoop in and do the job it was designed to do. Okay. But when we over harvest the cancer cells, so there's 2 main cells. There's your daughter cells, which are the fast, rapid turnover cancer cells. Okay. That's what chemo and radiation like to go after. Then there's the dormant stem cells that are like the mother cells, and they hang out quietly until the daughter cells are pushed back, and then they step into the ring, and they are much more difficult to kill, much more aggressive, and they mutate much more frequently. Okay. And so when we overtreat with this maximum tolerated dose, we can wake up the mother. It becomes much more challenging to address. But when we push back the daughter cells just enough, maybe don't take them below 20%, right? Then there's an opportunity to keep the mother cells dormant and to bring in the rest of the body to do its job, be it the immune system, the other hormone signaling pathway systems, et cetera. So that's the way I approach it for myself, and that's how I've approached it with my patients. And so when I've now helped people understand that the goal is not to, if you see nothing on the imaging and your tumor markers are normalized, well, that's just added bonus, right? But that's not the goal. The goal today is to understand that cancer is a manageable disease process, and you can die with cancer, not of it. And so that's where we're trying to shift the mindset, right? There you go. I love it. And that really takes so much, it takes the pressure off the oncologists as well, right? It helps people understand we can work with the body, not against the body.
Yeah, sometimes when I talk to oncologists here in Brazil, they're really closed about it. But we have Aline here. I bet she's here still. She's an oncologist. She's very smart. She sees all my podcasts. She went to, I did a workshop with Ahmed. Here she went. So but she's going to the States, you know, you can bring her in. Yeah. She's going to live in the States. Yes. So, and she's an oncologist. She's a pretty good one. She's very smart. You see, Aline, I hope you listen to it. I never asked you about it, but I'm telling Nasha about you. So if you're not going to be with me, you may as well be with her. Nice. And she knows a lot about the metabolic pathways in cancer and how I think and how you think. Great. So she's a good person. If you can convince her to work with you, she's great. And the other oncologists, nonetheless, I have some that talk to me, and slowly I'm beginning to convince people that I should be heard sometimes. They don't believe in metronomic chemotherapy, and sometimes if it's like none or everything, like 80 or 80, 8 or 80, we say in Brazil. If you don't have everything, I won't give you anything. So if you don't tolerate this chemotherapy, it's nothing. They never think about insulin before chemo here. They're against it. And I don't know why, because we have really interesting published studies from Slocum, and we have other studies published. I think they should be looking into it. It's very safe. I mean, we do tests. We do insulin tolerance tests in labs every day when we're looking for other stuff, and GH testing and cortisol testing. And it's regular. I mean, why not doing it inside a hospital with a doctor by your side? I don't know. But I think about this metronomic chemotherapy is exactly what you're saying. It's not kill the messenger, right? Yes. You may as well kill the patient, right? And together with the metabolic approach, if you give the supplements that keep these stem cells not so comfortable, maybe even the stem cells will be sensitive to the eradicated. Not all of them, but some of them. I mean, but if you cannot die from the cancer, it's good enough, isn't it? You have more time with your family, right? And in the meantime, you can work your emotions, right? Because it seems that every cancer patient I ask, did anything happen 6 months before the diagnosis? 1 year before the diagnosis? 90% said yes.
Yeah. And that's based on even Dr. Lawrence Lashan's work, who we just lost a couple of years ago. He made it to the ripe age of 100. But his work from the 1950s and his research in cancer patients was just that he found that anywhere from 6 months to 2 years prior to their diagnosis, there was some kind of big emotional shock or some big emotional trauma. And then even that, he was kind of considered controversial, but he wrote an amazing book that's still very relevant called Cancer as a Turning Point. And the back of that book has a little workbook. And I recommend that patients get hold of this book. This book was actually recommended to me when I was in medical school by one of my professors, who's now, my God, Stephen Messer, man, this man is like man with 9 lives. He's like 4 or 5 times into terminal, colorectal cancer that's gone amok. He's still here to tell the story, but he recommended that book to me early on because I was still kind of coming in and out of progressions there for many years. And I've even had a couple over the last decade when life took its toll and I stopped listening as deeply as I should and then kind of pulled my reins back. But that book was very, very instrumental for me in my own healing journey, and I recommend it often. I do want to come back to a moment though. You mentioned something about insulin. So I'm going to be unfavorable for you and your listeners who are fans of insulin potentiated low dose chemotherapy. So I too was trained in that 25 plus years ago. Very excited about this because we see amazing pushback on the tumor burden. We see amazing pushback on the tumor markers. So the tumor burden was revealed on the imaging that it definitely does something. It shrinks those tumors, and it definitely reveals on the tumor markers that it lowers those numbers. But here's the caveat. 25 plus years ago, we knew nothing about the role of insulin in cancer or the role of insulin growth factor in cancer. So I would see these patients and I would see not hear anything. And then because I'm weird, I go and check on obituaries pretty regularly. And I would see that they passed on within a couple of years from when they had this amazing amazing response to IPT.
And were they on a ketogenic diet by then?
Well, this is way back. This is way back in the day. This is right. So no one was talking. I mean, really, ketogenic diet in the cancer world has only been able to come out of the closet and be talked about for about the last decade, maybe 12 years. And so, but prior to that, like IPT was all we knew, all we had. If you ever talked about fasting a patient or keto with a patient, I had to come at it with a way of talking about patients just lowering their carbohydrate intake. If I ever said ketogenic in my practice, I would have been shut down in 2 seconds. Right. So I'm already being a naturopathic doctor in an unlicensed state. I was already treading uphill. So I had to be very, very careful of how I worded things. Language was very important. But at that time, I started seeing other patients going all over the world, to Germany, to Mexico, to different places in the United States, and getting IPT. And then they'd come back and see me when they were having recurrences or progressions. And that's when I started to put 2 and 2 together, and the literature started to catch up. And I was starting to employ more fasting and ketogenic diet and caloric restricted diet with my cancer patients, that I started to realize, because I also started testing in everybody, insulin and insulin growth factor 1 in every single patient, that I realized that a single treatment with insulin potentiated chemo, a single treatment would often cause their IGF-1 to go up for at least a year after that single treatment. And it was that moment when I made the connection of that stops now. We've learned too much about how to metabolically push things back, that we can get patients in a fasted state or a state of high therapeutic ketones, even with exogenous help, into a metronomic chemo, meaning no need to add in any insulin, and you're getting the same response without the rebound effect that the insulin growth factor inevitably will have in this patient population. So I now am on a mission, and it's not a popular one, because there's a lot of doctors who make a very good living. There's a lot of doctors making a very good living on IPT. I just say, please just drop the I part of the PT and do the fractionated metronomic part in a fasted or ketogenic state, and you will see what I'm talking about. But here, you have to remember the mindset of people who practice. They're excited in standard of care if a patient with stage 4 cancer is 3 months, out from a treatment and still alive. That's considered, we mark that as a success in standard of care oncology. 19 pharmaceuticals over a 17-year period of time, the average overall lifespan they gave was 2.4 months, and we celebrate that as a victory, as a success. So when my colleagues who practice integrative oncology see a patient living beyond 3 months or 6 months, they're celebrating, even if they drop dead a month later. They still don't see. So I'm personally in for the long game. So I don't think that 3 or 6 months is enough time. I shoot for something longer. And so I want folks to go at this with all their best foot forward. And so if I can get my hands on somebody before they've done insulin potentiated therapy, we'll do keto potentiated therapy. If I see somebody after they've done IPT, I work very hard, not successfully most of the time, unfortunately. So I need your listeners to hear this. I work very hard to get that insulin down as quickly as possible. It is not easy.
So let me ask you a question then. That's very interesting. We have very, very famous doctors even working.
I know.
I know.
I studied with them all. I trained with them all.
Yes. Then the question is, do you think, and that's a very important question for me, I think, because I haven't done it, but I'm flirting with it. So some patients, when they have like big tumors, like terminal cancers, and the size is an issue. I always put my patients on a ketogenic diet. I always give them metformin. I always give them berberine. So I always work with very low glycemic index. I sometimes measure GKI, and it's below 3. Even so, do you think that if we do insulin potentiated chemotherapy for a while, if the patient is doing all this already, the only moment he takes insulin is during the chemotherapy, do you think the impact will be as big as a patient who is eating carbs and, has insulin resistance and is not doing the diet? Do you think it would be different? The results will, because if you get a patient, I did EPT, okay, but I was eating carbs and ice cream because my oncologist said, eat anything you want, just don't lose weight, like they do. It's different than a patient that comes to you now and he's on a ketogenic diet and it's not responding, because we have patients that are on ketogenic diets, are on GKA below 3, they are not responding. So these patients, if they do EPT, do you think they will respond the same? Or do you think it will be better and maybe there's a chance that they don't have a recurrence afterwards if they gain time and you can work with the insulin resistance?
So I would love to say that there is a difference.
No, and I'm asking if you have...
I'm a bit of a stickler with regards to testing. So my mantra is test, assess, address, don't guess. So what happens is, because I was seeing patients post-IPT, I made assumptions about perhaps they were already metabolically broken, or perhaps other things were going on, or perhaps they were high carb eaters. So I'm only seeing the aftermath of insulin and insulin growth factor after they've done this. But then I've had enough patients who've worked with me ahead of time to get into a normalized IGF, a normalized insulin, who then take off to do a little pushback because they got panicked. Right? There wasn't moving fast enough for them. There was still some tumor there. So they rushed off to do it. And then it was like almost impossible to get them back into normalization after the fact. I will say that it's definitely easier to help them normalize if they started out with better metabolic flexibility than if they didn't. So if you had to put 2 and 2 together. So here's what I would suggest, because I have had a few patients who've gone to some of these clinics. They're my friends. They've been through my training. They know my feelings around this, right? So, and so I just strongly say, because here's the thing, they don't test. No one tests insulin growth factor ahead of time. You do. Always. So now you're watching it. So now you're going to be watching it with a new critical eye.
No, I always watch it, but I don't do insulin yet. So.
Right. And so that's the piece here. So when I send them there and I say, okay, because they say, well, we're going to use a really tiny amount. I'm like, do me a favor. Let's see what it looks like if you do it without the insulin, because their goal is to get the glucose. Really what they're trying to do is get the glucose below 60. But if I have a patient who's already in therapeutic ketosis and they go over for a therapy that historically used insulin as part of their metronomic low dose chemo, I fast the patient for an extra day or 2, right? And they can get their glucose below 60, no problem. And that's where, in that point, I'm like, they're going to tolerate it better. They're going to feel better. They're going to bounce back better, and they're going to maintain better. And so those are the things that in the handful of times I've been able to convince the doctors to do that, they're always like pleased. And what they tell me, this is what comes back from my well-meaning colleagues, is their own assumptions are what are keeping the patient from being successful. Their own belief systems are what are keeping the patient from being successful. When they say the patient can't do this, it's going to be hard for the patient, they can't get their glucose down that low, that's their belief system that's now effing with that patient's reality. And so I want my patients to know that they're far more powerful than they've been led to believe, that we can in fact get them down into a nicely suppressed glucose level without having a rebound with insulin on board. And we can get them through this process safely and effectively. In fact, I see less side effects with keto potentiated therapy than I do with insulin potentiated therapy. Anybody who's ever had IPT, I've been in plenty of clinics, it's not comfortable when you are coming down that low, that fast on your glucose, and then having the rebound effect after it wears off. It's very, very hard on the body. And you as an endocrinologist, I'm sure can appreciate that, because it has all kinds of other factors and how it's messing with the cortisol and the thyroid and the adrenals and just all the things. So I would really strongly suggest to play with the ketogenic potentiated therapy or the fasted potentiated therapy. And even patients who are pretty metabolically flexible, even just metronomic, so getting down to like 20 to 30% of the chemo dose, is already more effective in my experience than if you're trying to do the 10% dose with insulin. So I think that we have room to discuss, because we've learned a lot more in the last couple of decades than we ever knew for the people who were my teachers and who presented this. And I'm always still kind of shocked when I see these conferences still happening and so many doctors still using it. And so I am waiting for someone to show me their data on the pre, post, during long-term follow-ups of these patients on pre and post insulin and insulin growth factors, and then their response over time and their maintenance of disease over time, because they're getting caught up in the myopic state of pushback on the imaging and pushback on the markers. That's where they're putting all their focus. But I'm looking at all the other factors of their terrain, which I know we're getting ready to talk about next, which are markers of inflammation. So C-reactive protein, sed rate, and lactase dehydrogenase. Watch what happens when someone gets on insulin to their lactase dehydrogenase. I mean, it's kind of frightening. And that's one of our really good markers of oncology. So those are the places that I think we can do better. And it's not to say, I would personally not do it, but if you're going to do it, you'd want to spend time getting that patient as metabolically flexible as possible. You're going to want them to be on and maintain a therapeutic state of ketosis, meaning blood ketones above 3 during their entire bout of IPT. And then you're going to make sure they are being hardcore with their therapeutic ketosis after to help suppress that insulin rebound effect. That's a lot harder work on the patient doing it that way than the other way.
You know what I have been doing, because in Brazil, it's impossible anyway to convince the oncologist to do it, and also to the metronomics. Unfortunately, they don't want to lower the dose. Weird. But you know what? It's funny because I told my patients, I have some patients that are very good at fasting and doing ketogenic diets. And I have this sarcoma patient that she's great. She was supposed to be there 2 years ago. And then she started the diet alone. She was on morphine patches. And then in 1 month, she was out of it and walking again. So she came living in my town. And we did lots of stuff, lots of protocols, IV. We did vitamin C. We did sonodynamic therapy. And then this doctor decided to operate on her. And she still had the tumor. We were kind of against it. But she chose to do it, and after it, she had metastasis. And then now they decided, okay, we're going to do chemo. And I told her, she said, oh, I want to do insulin. I said, no, you know what? Let's fast like 24 hours before until 2 days afterwards. And she's doing it, and she's coming to chemo with 60, 55. But since she's on ketosis, she's feeling great. You know, we have this study, the longest fast published is 281 days. You know, guys, if you've read this study. And the guy, he had like glucose levels of 30, 20, and he was riding his bike to the hospital. And he was great because he was on ketones, you know. So that's not an issue. So if you manage to be on a ketogenic diet and being keto adapted before you begin chemotherapy, of course, you won't be able to have to tolerate lower glucose levels if you're not trained before that. So you should be on a ketogenic diet long before if you can. And then you start fasting. And then if you have already this trained, if you're seen by a doctor or a nutritionist, okay, so my patients all are. So she had this amazing response to the chemotherapy. And her hair is like growing back way before time. And doctor said, okay, I was supposed to prescribe you 12 sessions. No, I think I'm going to do only 8. Because this sarcoma is not supposed to respond to this chemotherapy.
Well, exactly. Most sarcomas don't.
But it is responding. And that's very interesting you're saying that, because I was doing what I can. So I tell them, go faster and try to not to eat anything beforehand and afterwards as well, to potentiate chemotherapy and to decrease the side effects. Because we know that our body is resilient. It's able to slow down, to be senescent, right? But cancer is not. And even the stem cells, if you fast, they can get more susceptible to chemotherapy too. Exactly. So now my challenge is to convince doctors to lower the dose, at least in those patients that have side effects, you know. But still they don't. But that's very interesting. I never read anything about the IGF-1 being high a year after IPT, because and since I have never seen literature about it, but your experience means a lot to me. That's very interesting. And I think so. I always measure IGF-1 and IGF-BP3, and I look into supplements that can lower, they can increase IGF-BP3 so that you have less IGF-1. And I always look into LDH too, so that's why I use the chloroacetate as well. So
love it.
Very interesting. Very interesting. Yeah. I think we have to talk more about that too. Yeah, and maybe discuss this with all the doctors too. I mean,
Exactly. Well, and to, you know, like, I just think it's very interesting that you're, you know, what you're talking about, just even simply fasting, we're giving our patients such a running start even if they're not getting the metronomic or the even just dose reduction chemo, it's still, that's all thanks to Dr. Longo's work and others, like these patients still always do better. And then if you could take it down a little bit, a lot of doctors will be willing to take it down to 75%, which is still not low, but it's like you said, if patients come in and say, I'm very sensitive to drugs, I'm demanding this, our patients really can demand it. We kind of coach them and train them how to say these things. We have one doctor in the United States who's willing to do what he calls low dose chemo, but it's a 50% reduction. Now, still better than nothing, especially if it's partnered with the chemo. But when you can get, and here's the irony, they're willing, you said this earlier, they're willing to pay for full dose chemo, but they're not willing to pay for low dose chemo, which is the most ridiculous thing I've ever heard in my life because it saves the insurance, it saves everybody money.
Yeah, but the doctors don't get commission.
Yeah.
They have their part. The clinics, they have money for the protocols.
And it's just crazy because here is something that we see work over and over. And, I'm shocked when I do finally have a doctor who sees a patient doing keto potentiated or fasting potentiated, or even patients who do lower dose chemo with fasting. They're always marveling at how much better the patients do. The other thing we strongly encourage is almost every single patient going through chemo, I would say every, there's probably a caveat or two, take steroids as a pre-dose before they do it. That is honestly, forgive me, but pissing in the wind.
Yes.
And so I really encourage my patients to avoid the steroid at all costs. And I'm like, if you go in fasted, you already lower the need for that steroid. If you were going to need a steroid, you're in a chair in a hospital environment that if you're going to have a bad reaction, you would have had that bad reaction even had you taken the pre-drug steroid. And they're going to give you the IV drip of it right then and there, and you're going to be fine. So I tell patients, if you feel like it, take more of the anti-nausea meds, take more of the benzodiazepine meds.
Don't take steroids.
If you feel like you need that, right. Don't take the steroids because then here's the crazy thing. We have tons of evidence. This is why I don't understand why there's not a bridge of understanding in the insulin and IGF world and the insulin potentiation world. We already have the literature showing what steroids do.
The increased mortality.
To our blood sugar. Yeah. To our steroid, to our blood sugar. Yeah, exactly. Our insulin or insulin potentiation. It's like, so why do we not, we're willing to see that, but we're not willing to see that the insulin can do the same thing. It's because they're both increasing insulin. Obviously, one is direct, the other is indirect. And so if our patients can avoid the steroids, first of all, our patients will always tell us they feel better. Because everyone always has that false sense of security day one on steroids because everything's so overly suppressed. And then all hell breaks loose. And they're like, I always feel the worst on day 2 or 3 after. I'm like, well, that's because the steroid is worn off. And now you're dealing with all the other things going on. So if you come into it fasted, as you talked about, the day or two before, day of, and day or two after, these patients are smooth.
Yeah.
They don't have that shock to the system. They're sleeping well. Their anxiety is managed. Their side effects are managed. It's incredible how much we can do without that. So I really encourage my patients to avoid the steroid at all costs. Again, if I'm lucky enough to get my hands on them, because you can see it, you can look at their labs and know exactly when they have their steroid.
Yeah, glucose goes up, insulin goes up, they lose muscle mass.
Everything.
They kicked out of ketosis.
Exactly. And then immune system tanks, their neutrophil to lymphocyte ratio goes in the toilet. It's nuts. Like we do all of this as a CYA, cover your ass in medical system. And yet it's actually it might be lazy doctoring or lazy nursing because we just we don't even ask, we don't even question it. And yet it causes so many harmful side effects and really takes away the potential we have of utilizing the power of what's happening in the patient to drive this. And so that's where I feel like we're giving an opportunity back to the patient to be in control of something that they feel so out of control around.
Yeah. So let's talk about this.
Shoosh.
This is her book, guys. So the Metabolic Approach to Cancer. So we've been talking a lot about metabolic approach, but I'd like to talk about this book, about the terrain. So Nasha, she has this masterpiece here. Of course, you bring about the terrain, metabolic terrain. So I took this test. I had irritable bowel disease. I had Hashimoto's. I even had positive TRAP, so I had Graves as well. At the same time, I had Hashimoto's, so they didn't know what I had. My fan was 1 to 640. I had kind of psoriasis too, and I had asthma, and I had migraines. Yeah.
Oof.
So when I found my ketogenic diet, yeah, and I had anemia. So everyone thought I already had a cancer when I was 20.
Wow.
So after medical school, after I was an endocrinologist, after everything, I found out gluten was trash. And I went on a ketogenic diet alone. No one taught me anything. I was finding out everything by myself after, yeah. And then in 30 days, I was better. In 3 months, everything was better. I didn't have anything until today. I'm fine. So I believe you. And when I took this test, I said, okay, I'm going to answer this test faithfully. She has this test here. Before I began keto. So I was like,
wow.
I was really, I would have all kinds of cancers after this. And then I said, and then I'm going to answer it now, being me now. And I was so well. I said, oh my God. So, and it's so funny because if it wasn't tragic, right? Thank God I found ketogenic diet because it saved my life before I had cancer. It's amazing. So I wanted to talk about the terrain. So let's talk about the terrain here because I think this is really important. I think we don't know. After I began treating cancer patients, I realized there's a huge potential for preventing cancer from coming, and no one is looking into that. So everyone that reads this, that studies cancer metabolism has like an obligation. It's compulsory. You can't say no. You know, God is seeing you. You have to do something about it. You have to tell people, even if they don't believe you, right? So I'd like you to talk about the terrain.
Sure. You know, it's funny. I'm trying to think of what era this came out of, but there was this concept. There was we've had this lovely, several thousand-year history of cancer's always been, right? We've always had cancer around. No one's ever pretending that it's a disease of modern times. It's certainly worse in modern times. So that should tell us something, right? But we always had different ideas. So like people like Virchow, he talked about cancer being a disease of a wound that won't heal. So this kind of chronic inflammatory process, which there's elements of that are very still true and spot on today. And then we had this concept of seed to soil or soil to seed theory, which was very much about the environment in which our cells live in and the cancer cells live in is all about keeping things, either actively cancering or actively not cancering. And then there's concepts of like Beauchamp versus, Louis Pasteur, this kind of battle of do we create disease or do we catch disease? And so we kind of took the we catch disease approach for the last, couple hundred years to say that it's something outside of us that has to be, that we have to kill, we have to attack. That's the antibiotic, the anti-hypertensive, the anti-cancer agent. And so our medical ideas have been just that. They've been ideas, they've been put in practice. Certain elements have stuck, certain elements haven't stuck. One of the elements that came to be in 1914 was Dr. Bovary's idea that cancer was somehow a genetic disease, a genetic aspect of our chromatins, that they somehow got mutated, and that's what cancer arose from. And that's what we believe still today in standard of care oncology, despite the fact that people like Dr. Otto Warburg and many of his predecessors have come back to say, well, if this was truly a genetic disease, if you removed the nuclei, the sort of database of a healthy cell, and you replaced the database, the nuclei of a cancer cell, theoretically, you should turn that cell into a healthy cell. And vice versa. So if you took the hard drive, the nuclei out of the cancer cell and you replace the nuclei of a healthy cell, if this was a genetic disease, that would turn it into a cancer cell. That doesn't happen. Those studies are called nuclei transfer studies. They've been repeated hundreds and hundreds of times, and they still come up to the same conclusion, that this is not directly related to a genetic disorder. What we are understanding is upstream from that at the level of the mitochondria and the metabolic, and therefore this sort of seed soil concept being revisited in a more modernized way, is the health and vitality of our mitochondria, and the cytoplasm in which they swim inside of our cells is where the magic is happening. That if those things are healthy, if the pool water, the cytoplasm is healthy, and the little organelles of the mitochondria are healthy, then we prevent DNA mutations, DNA damage. And so it comes back to what are we doing to contribute to the health and well-being of our tissues, of our cells, of what's inside of our cells, and to the tissues and the organs and the container in which it all happens. And this is where we come back again and again. And so the terrain, to me, from my 30 some years of practice, I kind of have broken it down into 10 categories. There could be more, there could be less. You hear different variations on the theme, but people like my hero, Mina Bissell, she's a really well-known oncology researcher. She started doing her research in the extracellular matrix. So kind of that
I love that.
The cytoplasm, the swimming pool that everything's in, back in the 80s, and everyone poo-pooed her, right? She's still at it. She's still up against a bunch of naysayers, that this woman is on to something, right? And has been all along. Even people like, Mukherjee, who wrote The Emperor of All Maladies, who really believed that cancer was a genetic disease. He kind of went out to disprove the concept of terrain or the concept of metabolic or mitochondria as the root. He actually was so compelled by what he learned that he's switched gears and understands that even the DNA is protected by how we take care of our soil, our terrain. And so for me, the 10 main drivers are epigenetics. So what were our propensities? What was handed down to us from previous generations? Not to say that it's stuck in stone, but it's to say that we have certain tendencies that are part of our upbringing, part of our cellular memory, but we can do something about that. We can still change its expression. Then we look at our metabolic processes. How are we fueling those cells? Are we fueling them with too much sugar, too much protein, too much fat, the wrong kinds of sugar, fat, and proteins, the wrong types of macronutrients, certain toxicants that are now in our food supply around the world that we can't get away from, et cetera. Then we look at toxicants in general. I alluded to that. It's no longer if you have toxicity, it's how bad is it, and how does it interface with your own epigenome. And then we look at your microbiome, which just a couple of years ago, everyone pretended didn't exist, didn't have a role to play.
And now it's in hallmarks, right?
Thank you, right? It's one of the big hallmarks, right? So is metabolic in hallmarks. So is epigenetics in hallmarks. And so you'll start to see here that there's an overlap between the hallmarks of cancer and the terrain as well. So I love that you brought that up. And then we get into the immune system, which is now like another hallmark is immune evasion, is another hallmark of cancer. So we've also just come out of a 2+ year pandemic where if you didn't know about the immune system before, you do now. And then we have inflammation. You've already alluded to that. We're in an inflammations nation society where we're all inflamed today. That's also a hallmark of cancer. Angiogenesis and our blood circulation and oxygenation. That's another hallmark of cancer, hypoxia and angiogenesis. And then we get into hormone metabolism and hormone metabolites and how our bodies process the hormones endogenously, what we naturally make inside of us, but also what we're being exposed to exogenously, because we're all now swimming in a big swimming pool of endocrine disruptive chemicals as well. And then we look at stress and circadian rhythm. So you and I are talking to each other. Exactly. Shift working, screen time, EMFs, blue lights, things that did not exist a few decades ago, definitely a few generations ago. And so here we are with a whole new stressor into the system. And then the final piece we've already alluded to earlier is that mental emotional piece. Like, how are we, what kind of trauma, how are we mentally mature, emotionally mature? How are we, emotionally handling the things around us? So those 10 drops in the bucket are how I evaluate someone's cytoplasm and their mitochondria and kind of how things are functioning inside the body to what they're being exposed to outside of the body. Remembering that our mitochondria are they're just little signaling agents. They just take in information, whether it's emotional, whether it's from the light, whether it's from food, water, air, soil. All of that information goes in and filters through our mitochondrial filter, if you will, making those mitochondria function either efficiently and effectively or deficiently and defectively. And then everything kind of trickles on from that. That's when we lead to the genome being at risk. That's when we lead to further breakdown of our energy pathways. That's when the body starts to shift into other metabolic pathways to pick up for where it's left off because of that shift. And that's what leads to chronic illness and cancer. And so it's just incredible to me that we talk about the terrain drops in the bucket, but we also have this understanding of of the hallmarks of cancer. And yet all of the drugs we design today in standard of care oncology are to target those hallmarks of cancer, but no one in standard of care oncology asks what set those hallmarks off to begin with.
And it's impossible to treat cancer if you don't tackle this, if you don't approach this, because people, most of people will die from the cancer. And as you said, all the new drugs and they're approving drugs in an accelerated way without phase 3 studies. And they all have to do the phase 3 studies within 1 to 3 years. 80% don't, and they're still on market. And this is published, right? This is published. I'm not saying something out of the blue, out of my mind here. So, and most of these drugs, even immunotherapy drugs, which are new and promising, right? They extend lifespan for 2 to 3 months in 30% of people. No one tells this. No one tells the patient this. They say, oh, this new drug is great. It's going to work. Okay. You have to be positive about it. Okay. Yeah. But I think it's important just to realize, we failed. The system failed. Oncology failed. I'm sorry to say this. Yeah. Okay. But I'm an endocrinologist. And I've been through this. My father died of lung cancer. My grandmother died of breast cancer. My aunt had lung cancer too. I'm around. Everyone has cancer now after COVID pandemics and after all the spike contact. I can't say I'm an anti-vax all the way because I took my vaccine. But I realize and I see patients who are coming back with cancer diagnosis out of the blue. So I hope people will study this properly, okay? I don't intend to do anything here, political commentaries, but after the pandemic, cancer is to the roof. And people are getting fat because they were at home. They're depressed because they were at home. They're anxious. Suicide rate, like in the States, is the first time, like after 2 years, the life expectancy is decreasing because of suicides and obesity. So guys, something's wrong here. Something is really going wrong. And cancer is up, Alzheimer's is up. That's why I study both of them. I love them because they're related. So come on, guys. If you don't work your terrain, you won't solve the cancer problem. How much money has been spent? Nasha, tell us. How much money?
Over $1 trillion. We've just bypassed the trillion mark. Cancer is expected to overtake cardiovascular disease as the number 1 killer globally.
Yeah, it is.
Right now, it's neck and neck.
In Brazil, it's the second. But that's a tie. It's a tie.
In 12 EU countries, it's already number 1. In the U.S. study just posted this week, it's now neck and neck with cardiovascular, but it's expected to overtake it. And so to your point, it's like we keep going after the single target that causes the single tumor process. This is the experiment we've been on for over 70 years now, and over 50 years since we claimed the war on cancer. And to your point, we've not made much headway. And so this is the place that I always tell patients, you cannot heal from the soil in which you got sick. You have to do your job, look under the hood, and address all the things that have been ignored or suppressed for a very long time. So one of my patients, I love how she describes it. She says, having cancer, first of all, most people would say to me when I was still in private practice and even to the doctors that I train now, that they were healthy until they got cancer. That is not possible.
It's impossible.
That is absolutely not possible. And so one of my patients described it perfectly. She said, my cancer was trying to give me signals for many, many years. And she goes, it was like putting the sticker over the check engine light in my car and ignoring it and still driving it down the road until one day it just wouldn't drive down the road any further. This is what most of us are dealing with. And so this is where we have all these awareness campaigns and these blue ribbon campaigns, and we're putting all this money into the cure for cancer. No one is talking about the prevention of cancer.
No one.
No one's talking about how do you look under the hood and prevent this? How do we start screening better? How do we start educating people to understand that anything they put in, on, and around their body is going to play into their health or their disease process? How are we not allowing people to understand that they're far more powerful than they're led to believe, that it's not a bad luck process, that you're not a sitting duck, you're not just waiting. It's a wake-up call. You called it earlier so beautifully, the messenger. Don't shoot the messenger. And that's what we've been doing. We've been shooting this messenger through chemo, radiation, surgery, targeted therapies, hormone blocking therapies, immune therapies. It's crazy. So let me give a really nice example. My colleague, who also wrote the foreword to another book that I co-published on mistletoe and the future of integrative oncology. It's good. Huh? Like
I love
my
mistletoe.
Colleagues and I, we're very proud of ourselves. It's so powerful. But Dr. Luis Diaz, he's who was the initial primary investigator for the mistletoe trial at Johns Hopkins. He then later got pulled over to Sloan Kettering, where he's the head of solid tumor oncology. Brilliant man, lovely human being, very open and amenable to integrative therapies. That's why he was willing to do this trial in mistletoe. But he just got written up in the last year, very famous now for his study about 18 patients that completely went into remission with Keytruda. And everyone's like, oh, the immune therapies, it's going to save us. But what you don't know is what's behind the scene there is, first of all, you mentioned these drugs work less than 20% of the time. And when they do work, they tend to only hold back the floodwaters for so long. What Dr. Luis does not have, what people don't see that's really about why these patients were successful is because instead of saying the drug was the success, the article should really be about why the patients were a success. Because the patients, they all had a particular mutation. They all had Lynch syndrome. Lynch syndrome is a very particular flavor. It's a very particular DNA repair mechanism. It's related to how we methylate. Okay, so right then and there, that says there is a lot that can be done in our own diet and lifestyle to help treat and prevent methylation. Number two, they were all under the age of 55. Yeah. So they were younger. Number three, they were all treatment naive.
That's great.
No standard of care, right? So here it is. They had the best possible chance. They had age on their side. They had a particular tumor type that's very dietary lifestyle impacted. We don't know how these patients ate or drank on this, but we don't know that. But when you see interviews, they all seem to be pretty health conscious people. And then they all had never been treated before. So they had this beautiful response. This is how standard of care should be done. We should be matching the treatment to the patient versus the other way around. And so this is where I believe we're going to move in the field of integrative oncology, is we're going to be able to really understand the patient in front of us to then know what we can do to help them become more successful at whatever therapy is applied to them, be it from even IPT, right? Or standard of care immune therapies or chemotherapies at a lower dose, or even natural therapies all across the board. Because it's just as bad if a patient's like, well, I'm not going to do any chemo. I'm just going to forego that and I'm just going to juice instead. That will kill you almost as fast as doing just full on chemo without questioning things either, because you're not addressing the issues. In fact, you often are worsening those as well. So that's where I hope that these conversations go, is if we're working on evaluating the terrain, treating the terrain, then the tumor either, number one, stays put, doesn't do anything. Number two, starts to get smaller and become less of a burden. Or number three, goes away altogether.
And all those three are okay. So patients should have shouldn't have like, expectations. Oh, if I'm not cured in 1 month, this is not working. Because in my experience, which I think you have like 1,000 more experience than me, when patients just drop the lifestyle changes and the diet and the supplements, all of a sudden the tumor does like this.
Yes.
What's your experience about? Because my patients, when they're like, I don't know if this is working, because it's not, the tumor is not shrinking. And some oncologists are very happy. Wow, the tumor didn't grow, and patients don't understand. They say, but this is good, your tumor is expected to grow. It doesn't respond well in the studies. So you're out of line here. Something's different. Go for it. Be happy. Yes. And they're like, no, I'm going to stop,
You're right. And you're to that point. And again, when I test, I'm like looking. So for instance, if they're on berberine, for instance, I'm still checking, well, do you need it? If your insulin growth factor is in a good place, let's maybe lower the dose and see if it stays still low. If it goes back up, then we know berberine was doing something. Things like vitamin D. Do we need to lower the dose? Well, let the testing help us. Do we need to take modified citrus pectin? Well, let's see if a galectin-3 responds. Do we need to take maybe some Celebrex? Well, let's see if CRP responds. So we're looking at testing to guide us, not guessing to guide us. And so the patient, obviously, if they get symptomatic or things start to grow, we're going to adjust course. But the labs ahead of time help us even understand, can we push back a little bit? Can we let go of some of these supplements? Can we let go of some of these off-label drugs or these other pharmaceuticals? And so we let the data of the patient, of the individual, drive the decision-making process, so that no one's guessing and no one's taking millions of supplements and wondering what's doing what. We know exactly what's doing what. And so my goal is to get people on as few things as possible to hold back and create this manageable disease process. That's my goal. And then if somebody is like, well, I want to take it a little bit further, maybe it's time to do some, maybe a low metronomic chemo. Maybe it's time to do a little bit of photodynamic therapy. Maybe it's time to do some intratumoral mistletoe injections. Maybe it's time to do some high heat hyperthermia. Whatever that may be, then and only then can you know what's required is if you're doing the testing and understanding what's before you. And so that's the other place I see is going to happen in modern oncology, is we're going to get much better at knowing what metrics to watch for and to guide our treatment decisions along the way.
Here in Brazil, we don't have as many tests as abroad. For example, lactate. We have lactate, and we always say, don't tie your arm before you collect blood. And they do it wrongly, and they do this the same. But we have lactate, venous lactate, and we don't have pyruvate to do pyruvate lactate.
No way.
We don't have pyruvate. So it will help a lot. But we have LDH. And also, when the patient is like skipping the diet, we can test and we can see the triglyceride to HDL ratio. And it goes up. I can tell the patient, look, you're eating carbs way much and you should. And the LDH is rising. And I teach my patient, you see, this LDH, it shows me you're not doing the diet properly. And your tumor is using this glucose. You're helping your tumor. Look. And I show them, this is the interleukin 6. We can dose interleukin 6 here.
Beautiful.
So you see, it went down. That's great. The diet is working, and naltrexone is working. The VH, the erythrocyte segmentation rate is going down. The PCR is going down. It's working, because sometimes the markers are still not down. But I reversed the patient's diabetes. I'm treating his. Because as an endocrinologist, I tell him, listen, I'm not only going to work on your tumor. I'm a doctor. I'm a clinician. I'm an internist. I have 2 residents, so I'm going to do everything I can for you. Oh,
girl.
And I'll try to help your memory, your fatigue. And we have many things, not only kill your tumor. You have to resuscitate you. You're dying, so I'm going to help you. And if the patient is healthier, feeling good during chemo, that's great. Listen, you're a victory. It's victorious already. It's great. So be happy about it. And I always try to show them the tests, because then they learn. In a while, they'll tell me, look, Janaina, do you think I can stop this because this is like this and this is like that? Because in the beginning, I usually have a bigger protocol, and then I tell them, look, this is the first one because we don't have many data. So as you respond, we'll start shrinking it. And I have patients that come every 6 months that are like cured. Okay, now they take like 5 things at most. Some don't take any because they're so great. But in the beginning, maybe they take more, and tell them, look, this is going to get better. So just go for it, and we'll feel how it goes. We have this test here that tests, it's like an inflammogram. It's a bit expensive. Not everyone can do it. It's private. You can measure TNF alpha. You can measure lots of interleukins. I'm trying to work with the how do you say, designer of it. She's from the university, to make like a cancer specific one. So and
let's talk. Let's see if we can do it.
It's something we can talk, because if she does it here, you can take it to the US too. It already works. She has this inflammogram, intestinal one, so we can dose interleukin 4 and interleukin 23.
Oh, nice.
So you can see if they have leaky gut, and she has lots of oxidative markers. She has a mitochondrial oxidative stress marker, so I really like preventively, and the systemic inflammatory one. I think it's very interesting because we can kind of see Th1, Th2 and inflammation in the patient. Since it's a bit expensive, I'm trying to make it more specific for cancer. So they do only one. Well, we can talk about it. I think it's very interesting. And the more we measure, It's like type 1 diabetes. The more you measure your glucose, the more you know how this impacts your life, and the better you'll get. Cancer is like this. If you have measures, if you sleep better, if you wake up feeling good, right? If you sleep earlier. So they think we're talking bollocks here when we say, circadian rhythm. Guys, there is this gland called pineal gland. Yes. It actually sees the light, feels the light, and orchestrates all genes in all your body. I don't know, guys, if you know that your liver, half of the genes work during the day and half work during the night.
Such chills.
Do you know that? Yes. So this is all because you expose your eyes without the glass, and you say, good morning, sun, good morning, sky. If you don't do that, it doesn't work. A good night of sleep begins in the morning when you look up and see the light, the real one, not the TV one. And cancer works.
Thank you. Yes.
And melatonin. I have this teacher. She's my friend as well. She said melatonin is a molecule of God, and I use IV melatonin here in high doses for cancer too, and for anti-aging as well. And I love it. And but the first thing I said, it's no use you take melatonin if you don't try to sleep earlier. You sleep better, wake up early, and stay away from TV all the time. Do grounding, talk. Aline, this oncologist, she loves grounding. She's always taking pictures grounding. So, and detox from bad friends, from family. Detox is not only like taking juices. Detox is like get away from what's making you harm, right?
Oh, yes, girl. Yes. Yeah, it's huge. We are the expression of the 5 closest people we are around. And so if like 3 of those 5 people are really toxic people and they weigh you down, they always want something from you, and they're not in alignment with your belief systems and your spiritual practice and all the things, like they're making you sick. You have to choose to walk away from, even if it's difficult. I've got patients who literally until they had their husbandectomy or their wifectomy, they weren't able to heal. They weren't able to heal until they got out of their toxic job. They weren't able to heal until they let go of that friend from childhood that they just couldn't seem to shake themselves loose from. And that sounds terrible, but it's necessary for our survival. And so those are the moments that you have to start to evaluate am I worth it? Am I worth it? And that often is where we do have some of our issues. So there's a group we've been working with called Humans Are Good Foundation. They're a nonprofit organization that basically do what I do, with the test, assess, address of the body. They do that of the psyche. So they have an ability to take this sort of this evaluation of our psychology and help us find the right way forward. And they baited on all of our patients, all of our patient advocates, and a lot of our patients. And what they found in the cancer population that we brought them was over 70% had a very common theme of not being heard or seen. And I'm just like, wow, to realize that over 70% of these patients that were evaluated for, their trigger and their trauma was that nobody sees and hears them.
That's so bad.
That's pretty lonely. And as you spoke to what's happening with longevity in the world today, we were even more isolated and even more shut down in our thoughts and our questions and our belief systems than ever before, that we're really in trouble now with regards to that. And so making sure you feel heard, making sure you feel seen, finding the communities that allow you to thrive and show up as who you are is very integral to you, both preventing a cancer diagnosis, but also improving a cancer outcome is going to be integral for your move step forward. And I think people are always expecting us to talk about what pill and potion to take, but hopefully, because you brought it up and we've brought it up a few times in our conversation today, what we need to do for our self-care on the mental, emotional side of things and dealing with some of those traumas and wounds is just as important, if not more so.
I see some patients that come to me now. They say, I only want to do the integrative approach. I won't take any chemo, any radiotherapy. And I said, okay, so now you're cutting your chances. What for exactly? I mean, something is wrong in your head. Let's talk about it. No, I think chemotherapy is bad for me. I said, yeah, okay. It might be, but it's bad for the tumor too. There are studies about it showing that it can work. We can discuss it, but I don't think it's appropriate, or I don't think it's a good decision, at least at first. If you deny your chances, something's wrong. It's like you're boycotting yourself. You're like,
Interesting.
that's something. This is in the process. It's like you don't want to heal. Because I understand the fear of chemotherapy, because there are some people on the internet that they're like, oh, this is going to kill you. Don't do it. Don't do it. Take juices instead. Okay. But I think it's a responsibility, our responsibility to tell people, look, cancer is a difficult disease, right? It's so difficult. No one seems to be able to cure, not even to slow it down, not even to prevent it nowadays, because they're not looking at all in its whole complexity, right? I actually drew my way of thinking. I put it on the paper. I'm going to show you afterwards. And about cancer, how I think. And I think it's so complex. It's impossible. One approach will cure it. I mean, we are not talking even about cure here. We're talking about living with it, but don't die from it, which is the most important. Be with your family, the ones you love, the most you can. It's like 1 day, 2 days, a year, 10 years. You have so much to do here in this earth.
Who knows?
If you don't think that way, you have to treat your head, your heart, your spirit. You have to do what we're talking about here. Like, this is a terrain. Something's wrong inside, deep inside. If you think you're not worth it, you're not used to anyone anymore, there's nothing for you, it's the same, whatever. Well, man, I think you should go deeper, right? Go deeper. Beautiful. I'm not the person to do it for you. I think only you are, but of course you need help. And I always have like a handful of professionals that can help doing that.
Good.
But I think if we don't start looking at this, and and I always tell people, I say, please just go to one appointment. But this oncologist, let's talk. Don't just throw it away. It's a chance,
right?
And then I see that people sometimes they refuse anything that can actually help them. They say, I hate broccoli. Okay, you can eat
I've seen
kale.
This too. Yeah.
You can eat kale. I hate kale too. I hate everything that's green, red, purple. I only eat what's white. Okay, now we have a problem here. We need a phonologist and work with textures. Maybe. I mean, I'm not gonna eat this, So they're always refusing what can help them, because I know ketogenic diet can be difficult if you live in carbo land for a while. But if this is gonna help you, and then you have the other personality. No, I'll do anything. I'll do everything it takes.
Exactly.
Whatever you tell me to do, I'll do. These people usually go better because they actually want to heal. They have some issues. They want to work on them. But people who have emotional, deep inside emotional issues, difficult ones, these are the ones that have the most trouble in diet adherence and sticking with the lifestyle changes, right? What do you think?
Yeah. Well, because I think that for them, food is joy. Food is love. Oops, hold on. Someone's coming in.
No
my
problem.
husband's ringing. Say hi. He's bringing me my keto lunch here. Janaina. He's bringing my sauerkraut keto bread goodie for later.
Sauerkraut is great.
I love it. Yeah, my little live food. But so I think like people find their food as medicine in a not so productive way. They're leaning on it for comfort. They're leaning on it for joy. It might be the only time they feel calm for the day. Those are things that get to be explored as well. It's like, where did food messaging go wrong for you? Where did you start to get away from really, you could nourish yourself differently? And even back to the point of people negating, conventional care. Like I didn't do conventional care, not because I didn't want to. Back then, it's because they didn't want to give it to me.
It wasn't offered.
And so, but it wasn't offered. So by the time I was further down the road and I was stabilized, then I knew I could do a lot of things on my own. But I want people to know I work very hard at it every day. The amount of work I have to invest into taking care of this container and managing this disease process is not for the faint of heart. It's not for everybody. And so in that place, what I want people to understand is that we can use standard of care better than ever. We know how to up it. We know how to take it to the next level. Exactly. We know how to use it more wisely. We know how to differentiate it to more of a personalized approach. So that's the piece here is in the future of healthcare, it's not going to be choosing either or. It's going to be about choosing what's best for the individual. Yet again, coming back to that conversation of we match the treatment to the person, not the person to the treatment. that's where I hope our medicine goes in the future. And through the lens of the terrain and through the lens of the metabolic mitochondrial machine that's helping everything dive or thrive is where we should be going with this. And I love when I talk to somebody like you who lives it for herself, because you had your own experience with it. It's also easier as a doctor to compel your patients to do this when you're doing it. So if I have doctors struggling with patients being compliant, it's because usually the doctor isn't compliant. So let's just call a spade a spade. I'll have some rotten tomatoes thrown at me for that too. But it's like when my doctor's like, well, I don't need to eat a ketogenic diet. Well, let's do some testing on you and see if that's the case. Yeah. Because 9 times out of 10, they're diabetic without even knowing it, or they've got toxins they don't know. Their HPA axis is all thrown off. And so we have to be accountable to ourselves, and then we need to be accountable to our patients. So we have to be willing to walk the path with our patients as much as walking the path for ourselves. So I think those are kind of my big take homes of our conversation today. And you and I should do this again, because there's a million things we could keep talking about. Yeah.
Of course. Guys, it's been amazing. 2 hours. We're talking for 2 hours. And it was so great. And I feel we have to do this again. And we can discuss pain in cancer patients. We can discuss mistletoe.
Yes. I would love it.
Let's do it in mistletoe. I love mistletoe. So I'll talk to you after this, and then we can arrange some time. You're very busy. She's very busy, guys. You know, it's difficult to get here.
So were you and all this. And it was harder for me just to figure out the technology.
But now
now I'm old school. I got it now.
Now you got it. You'll see how good the images are and the sound. You'll love it, and you'll want to do it every time. So I can't thank you enough. I think it was great. It triggered a lot of reasoning in my head as well about EPT. I love discussing this with you, because when I first heard of EPT, it was in the Metabolic Health Summit. It was talking to doctors that were doing your course, and they told me they were doing your course. And I said, but listen, isn't it a nonsense to give insulin to a tumor that loves insulin? And they said, no, but it is just at that specific point, and then they're on a ketogenic diet, and there's no consequence. Then I said, okay, if there's no consequence. Then I went to the literature, and the results were good. But no one was discussing the IGF-1 long term. So if you have this experience, for me, that's enough. I don't think I will recommend it unless as a last resource in tumors that are really big in a patient that's really like, you know, that nothing is working. Maybe I'll recommend it, but together with the ketogenic diet and fasting. With them if you're But I always see the IGF-1 in my patients, and I keep track of it in IGF-BP3 too. So I haven't seen them go up because my patients are all doing ketogenic diet or low methionine diet. So that's why it's working. So I haven't worried about it because it's okay. So I think what I'm doing is it's kind of it's okay. It's working. Yes. Yeah.
You're a rock star.
And I'm not. I'm learning every day. I'm learning every day from you. I'm learning every day from Ahmed. I'm learning from the literature and my own experiences too. And I can't thank you enough for it. Thank you so much for being here. I appreciate it. And please come back. My followers would love to see you again.
Back at you. It's such a beautiful time to be with you today. And I look forward to more. And I hopefully will see you in person at some conferences this year. And just a shout out to Ahmed. He has joined our team. He is the director of our clinical research. We are incredibly grateful. I mark my word, he will have a Nobel Prize in his lifetime. I know it.
I know it.
I'm just like, the man is so brilliant and so humble and so precious. And I love that we get to share in the celebration of him and all that he's teaching us and all that he will continue to bring to the field of integrative oncology. He's a game changer.
He's a game changer. I'll see you in Stuttgart.
Sure.
I'll see you in Stuttgart.
Oh,
my abstract was accepted for an oral presentation, guys. So.
I cannot wait. So I will see you over in Germany later this fall, my love. Best to you and all of your listeners. Grateful.
Thank you. Bye-bye.